Good evening, viewers. Welcome to Health Crisis program on MITV. Today's episode, we'll be discussing Placenta praevia. Health Crisis program is a program in which we inform and educate you about complex and difficult health situations. In the studio today to discuss Placenta praevia is a consultant obstetrician and gynecologist. During the course of this program, you have the opportunity of watching documentary on Placenta praevia. You also will have the opportunity in our Voice Pop segment to hear and see what people think and know about Placenta praevia. You also can be part of this program by sending tweets to our Twitter handle at MITV Lagos, and you also have the opportunity of making your phone calls to us, as well as health tips during the course of this program. My name is Dr. Austin Aipo, your regular host. We'll take a break, and when we come back, we'll have the discussion. Stay tuned. Welcome back. You are still on to Health Crisis, a health program on television where we discuss uncommon health problems. With me in the studio today to discuss Placenta praevia is no other person but a consultant obstetrician and gynecologist, a former secretary of Nigerian Medical Association Lagos State and medical director of Dayspring Hospital. Join me in welcoming Dr. S.K. Adebayo. Dr. Adebayo, you're welcome to the studio.
Oh, how are you?
Right. We are going to look at Placenta praevia, which is one of the complications, a complicating condition in obstetrics. I just want to know, what is Placenta praevia?
Thank you. Placenta praevia is a situation where the placenta of the baby is attached to the lower segment of the womb, either totally or partially. The lower segment of the womb, coincidentally, is the entrance to the womb. And that is the point of exit for the baby and the placenta at the time of delivery. So in a situation where the placenta is now attached to the entrance of the womb, it means that the possibility of the baby and the placenta to pass through at delivery becomes difficult or impossible. Now, placenta praevia could occur without identifying the underlying cause. In fact, as a matter of fact, the exact cause of placenta praevia is not known. But we only know some conditions that can predispose to it.
Okay, Dr. Adebayo, before we go into that, can we just let our viewers know how is the lower segment formed? Because you say it's placenta at the lower segment.
Yes. Let me just make it very simple. A womb is like a ball. We have the upper part we call the fundus, and the lower part we call the entrance we call the cervix. When a baby is formed in the womb, the placenta is usually, most of the time, attached to the upper part of the womb, so that the lower part, which is the passage in and out of the womb, is free, and the baby grows. Now, that is the normal position when a baby is formed, and there is placenta is in the normal position. But when we now look at placenta praevia, we are looking at a situation where instead of the placenta to be at the normal place, now we have the placenta in an abnormal place, yes, which is the lower part of the womb.
Yes, Doctor, I do know that after fertilization in the fallopian tube, the fertilized egg has to now come down. So what informed the position, the location? What,
yes. You see, usually when the egg and the sperm meets, they form usually in the tube. And this new couple now, the egg and the sperm, forming a new baby, a new future baby, takes their journey across the remaining part of the tube, gets to the womb. Now, if for whatever reason, instead of the baby to be attached to the upper part of the womb and start its growth there, coincidentally or accidentally now dropped to the lower part of the womb and start growing there. Of course, if a seed dropped anywhere, the root will start from that point. So you now see the placenta coming out to attach to that lower part of the womb. But it could be totally attached down there, or it could just be a little bit below the normal place. So, if it is formed at the lower part, then it could form the placenta praevia. Like I said, the exact cause of placenta praevia is not really known. But there are some conditions that have been found that could predispose a woman to have a placenta, instead of being at the normal part in the upper segment, to be in the lower part. So, should we discuss
yes,
that?
I think we should just, before we look at the predisposing factors and causes and all that, we've heard stories. People come to you and say, look, the placenta was blocking the way.
Yes.
That's where the layman will put it.
Yeah.
And then after certain things, prayer or whatever, that the placenta moved away.
Oh, very, very interesting. You see, usually, from the definition I said, it could be total or partial. Now, if it is partial, all that happens is that the placenta is not directly at the entrance of the womb, but totally at the lower. It's just at the lower segment, but partial. So, and usually, when the pregnancy is advancing, the womb is growing and expanding. So also is the placenta growing. So as the womb is growing, part of this placenta grow along with the womb up. And if it is just partial, at the early stage, maybe the first 4 months, 5 months, you can't see there is placenta praevia there, because this is a diagnosis that you make at the middle and the last part of the pregnancy.
Yeah, that's exactly what I wanted you to
so
tell
invariably, this as the pregnancy is advancing, what you see when you scan and you see that, oh, this placenta is a little bit close to the lower ground, to the lower part of the uterus. By the time the pregnancy is advancing, you now discover that the placenta has, let me use the word we normally do, migrate a little up. And at that point, there are really no problem. So at times, you do scan at the early stage of the pregnancy, you don't make diagnosis of placenta praevia because the pregnancy will still grow, the womb will grow, and the part of the placenta will move up, and there will be a lot of changes.
That's exactly what I wanted my people to know. But let me just quickly ask this question before we go on to...
All right.
Who owns the placenta, the baby or the mother?
The placenta is part of the baby.
Good. Yes. So, and what are the functions of the placenta so that our viewers out there will understand?
As you look at the placenta, coincidentally, I don't think we don't have it on the screen now. As you look at the placenta just form like a wrap, and now attached to it is a cord that connects to the baby. Okay. Now, the baby is like a stranger in an island. So the feeding of the baby comes through the placenta along the cord. The nutrient, the oxygen, everything the baby needs, all the nourishment, everything the baby needs to grow comes through the placenta. So it's an organ that nourished and make sure the baby grow to maturity. So that's why when you have disease of the placenta, invariably it's going to affect the baby.
Because the placenta also helps in excretion.
Everything that happens to the baby. The feeding of the baby, the growth of the baby, even the excretion of the byproduct, everything goes through the placenta. So it is a major anchor that suspends the baby and nourish the baby and keep the baby alive to delivery.
But the location, before we talk properly about this placenta, the location does not really affect the function vis-a-vis the nutrition, the excretion, or even the thing that sustain the baby, because placenta also plays a part in sustaining the baby.
Yes. The location has a thing to do. You see, most of the time when you have this placenta at the lower segment, the blood supply to the lower segment is not as good as the upper segment. So at times when you have a case of placenta praevia, you notice that by the time the pregnancy is about 9 months and the weight of the baby is supposed to be about 3.5 kg, thereabout, you may notice that the baby might just be about 2.5, 2 kg because there is poor nutrition because of the location of the placenta. So the location also plays a role. In fact, most of the time when you have the placenta at the lower segment like that, it will also tilt the pregnancy to even go into premature labor and deliver before time. When we get to complication, you look at some of these factors.
Okay, so let's quickly look at predisposing factor, or if there are causes, so that our viewers will understand how the placenta praevia comes about, if there are any causes, or what are the predisposing factors.
Thank you. You see, like I said, the exact cause is unknown. But we have some factors that from research and experience over the years of managing pregnant women, they have been identified as predisposing factor. Take, for instance, women that smokes. More women that smoke, they tend to have this placenta at the lower segment than women that did not smoke. Alcoholism too has been identified. In developed countries, the use of cocaine, has been identified. Then previous operations, people that have previous urinary section, previous fibroid operations.
Is it because of the scar?
Yes, because by the time you're doing the even termination of pregnancy has been also identified as a predisposing factor. By the time you scar the womb and the womb is healing, the area of the womb that heal, which usually is the lower part of it, is not as healthy as the other side. And when the placenta wants to form, there is tendency for the placenta to have tendency to attach to that area than the normal position. So then the age of the pregnancy, the age of the woman, most women above the age of 40 carrying pregnancy have tendency to have the lower placenta and the lower segment compared to women in their 20s and their 30s. Then also, the women that are extremely young, 15, 20, people below age of 20, has also been identified as a risk factor for placenta praevia. Then when you look at many pregnancies, so women that have been pregnant and are delivered about 4 or 5 times, they have tendency. Yes.
Pregnancies.
Yes. Then people that have any situation that predispose a woman to a baby to have a large placenta. Take for instance twins or triplets. Yes. Because the placenta is large, there is a tendency for part of it to extend to the lower segment. So those are the common predisposing factors.
But that does it have a role? Because you just talked about something that makes the baby to be large or placenta.
Oh yes, any disease that can make a baby to be large. Take for instance, multiple pregnancy, that make the placenta previa. Or in the situation where a woman is diabetic, it is not controlled, the placenta is large, the baby is large. So those are the common, those are the predosing factors. But at times, when you look at this, when you look at some patient, you couldn't even see any of the predosing factors, and right in your hand, you have placenta previa. So that's why I said the exact etiology is not really known. But we already know that among those predosing factors, they are more prevalent of placenta previa when you compare them to or another population of people who doesn't have those predosing factors.
Yes, you are still on to Health Crisis program on MITV. We are discussing placenta previa. Yes, we to try to define and explain to our viewers what placenta previa is. And we also touched on what the placenta, the function of the placenta, so to say. We have discussed also predosing factors. Since exact cause not known. We'll take a break now, so when we come back, we'll continue the discussion. Stay tuned.
Hi everyone, it's Mr. Sinti, and today I have the pleasure to be discussing with you one of the greatest organs that the female body and baby can produce together as one, which is the placenta. That's right, the placenta is an organ that it develops during pregnancy, and as you can see, it's located right here within the womb of the woman, which is the uterus. And so we're going to get into a discussion about its anatomy and its physiology, and I think you're going to enjoy it because it's one of the cool things about pregnancy that this placenta forms. Because the thing about it is the uterus where the baby is developing is inside the uterus. It's a really, really strong muscular organ, and again, it has to be muscular because it's this contraction of the uterine wall which is going to be forcing the baby out during delivery. But the thing about it is the placenta, and I thought I'd start off with just an actual picture of the placenta. As you can see in this tray, the placenta is delivered after the baby. It's sometimes referred to as afterbirth, and as you can see here, this is the umbilical cord right here, which is connecting to the newborn. And so it's an organ that connects the developing fetus inside the uterus. It's connected to the inner wall of the uterus, as you can see here. And so it connects to the baby via the umbilical cord, or the fetus, I should say. And basically, it allows nutrients that the mother is eating and gases, principally oxygen, that the mother is breathing in to travel into the baby, because whatever the mother is breathing and eating, it needs to go into the baby. And conversely, the baby needs to get rid of its carbon dioxide. And so carbon dioxide then goes into the placenta and then out, and the mother breathes it out of her lungs. It's quite remarkable. And also the baby needs to eliminate a little bit of waste as well. If you recall somewhere in your past knowledge, the baby is also producing nitrogenous waste in the terms of urea, and that needs to be filtered out by the placenta as well. So it's an incredible organ, and there's a lot of blood vessels involved, and that's what this conversation is going to be all about. But I just want to give you a little bit of background here. This is a non-pregnant model of a female anatomy here, and here you can see this sort of pear-shaped structure in the center. Here, the abdominal cavity. The intestines are removed so you can see this, but this is the uterus. Notice the inside. This is where the baby, the lumen, is where the fetus is developing, and this is where the placenta is going to form. There's an endometrium, a myometrium, and a parametrium, and the myometrium is very muscular, and the uterus sits anatomically superior to the female urinary bladder. And as you can see, here is the cervix, or opening to the birth canal. And so when you see this picture, this is kind of a familiar picture too. Here's the uterus, and so what we're describing as far as placenta is that this is going to be growing inside of the uterus here, and you can see here's the ovaries and the fallopian tube. Here's the cervix. So I like to show histological slides, and so this is the showing how many blood vessels. There's so many blood vessels in the endometrium, and so this is endometrium of the uterus is going to extend itself and form the female part of the placenta. And then here you can see the strong muscular wall of the myometrium and the parametrium here. So that's a look at the layers of the uterine wall. Here's an actual picture of the uterus. Here's the ovaries, here's the fallopian tubes as well. So this is what we're talking about, the uterus. And so what I wanted to say at the beginning of this discussion right out of the gate is that, the fetus, when developing inside the uterus, is basically enclosed, and they're basically swimming in this fluid called amniotic fluid, which is located inside this membrane called the amniotic sac, right in here, or a bag of waters. And so basically, what I'm getting at here is that the fetus is surrounded by this fluid, which means that its lungs are filled with this amniotic fluid. And so the baby isn't breathing air, which means that it needs to get everything from the blood of the mother. And so it needs to get oxygen from the mother's blood, and it needs to get nutrients from the mother's blood. It's not eating inside of here. So the only connection is this umbilical cord, which is really important. And it's the umbilical cord which connects to the placenta, which is located right here. And so if the baby wants to get rid of its carbon dioxide, it needs to be through the umbilical cord to the placenta. And so this placenta is really important. It provides the solution for the baby to get oxygen and get nutrients and rid itself of waste such as carbon dioxide. So the placenta is the solution. I want you to be thinking about that. So the fetus, as it turns out, let me attempt to make a drawing here of this. And so inside the uterus, okay, kind of a crude drawing of the uterus here. Okay, inside the uterus, what we're talking about is, let's switch colors here. So the fetus is sitting in here, okay, and here's the head, like that. And so what's going on is that the fetus is going to send up some blood vessels to the placenta. And so the blood vessels that it's going to send up are, and let me go with these first, are arteries. Okay, so this is going up towards the placenta, and this is going into the belly button here. Okay, so it sends up 2 arteries like that. And so we use the term arteries to describe a blood vessel that is taking blood away from the heart. And in this case, it's the fetal heart. So away from the heart, we're talking about the blood vessels called arteries. And so these arteries are traveling up toward the placenta. And so the placenta, let me draw in up here. I'll make it in yellow up here. Okay, like that. And so the placenta itself is going to be then providing, as I was saying, this is the mother's body. And so the mother is going to be providing in a blood vessel like this called an artery. I'm sorry, a vein. This is the umbilical vein, is going to be bringing oxygenated blood to the baby in order to get nutrients and oxygen. And so collectively, these 3 blood vessels are going to be enclosed in this tube called the umbilical cord. And so this is what the umbilical cord is right here. The umbilical cord is made up of these 3 blood vessels. And again, coming toward the baby in a vein and going away from the baby are these arteries. Okay? So this is perhaps a better drawing of that. So this is inside the uterus. Here's the birth canal right here. Here's the umbilical cord, which is connecting to the belly button. And so inside this, we re-illustrated. Inside of this, you have 2 umbilical arteries, like this, umbilical arteries that are coming up like that, and 1 umbilical vein, which is coming this way toward the baby, and it has oxygenated blood, and this is what's inside the umbilical cord. You're like, well, what's the story with the umbilical arteries? How come they're blue? Well, they're deoxygenated, and so the idea is that they need to pick up oxygen from the mother, and then it returns in the umbilical vein toward the heart over here, so that the baby can pump it through the body. So the umbilical cord carries blood vessels to the placenta. So that's what the umbilical cord is. And again, it picks up oxygen and it gets rid of carbon dioxide and it picks up nutrients. And this is a sonogram of the umbilical cord using ultrasound. So the umbilical vein, as I was mentioning before, is red. And so I color-coded that red because it's oxygenated. And it's bringing oxygenated blood from the placenta toward the fetus. And so we always...
Welcome back. The program is Health Crisis on MITV. We are discussing placenta praevia, and with me for the discussion is a consultant obstetrician and gynecologist, Dr. S.K. Adebayo. Well, Dr. Adebayo.
Yes.
Yes, we've been talking about placenta praevia. We tried to define placenta praevia. We looked at predisposing factors. We also looked at the functions of the placenta. How will the patient present?
Good. Like I explained earlier, placenta praevia is where the placenta is in an abnormal position. Basically, for clinical management, we divide placenta praevia into two parts. We have placenta praevia minor and major. Minor, just like I said, it could be partial. This is a situation where the placenta is at the lower segment, but it does not cover the entrance of the womb or does not cover the lower part of the womb. But the major is when the placenta covers the lower segment totally.
And cover the entrance.
Yes, cover the entrance. So why do we have these clinical differences? We have these clinical differences so that it could give us an idea. How do we manage this pregnancy? How do we deliver the baby? For minor, most of the time, if there's no bleeding, you can allow vaginal delivery.
Also, let's take a pause before we look into the management. Let's look at how will the patient present.
Fine. So, placenta praevia, usually in a classical way, present with painless vaginal delivery in a pregnant woman.
Vaginal bleeding.
Painless vaginal bleeding. You see a pregnant woman, usually from second and third part of the pregnancy, that is, we have pregnancy divided into three parts. The first 3 months is first trimester, second 3 months is second trimester, and the last 3 months is third trimester. Usually from the second or the third or early part of the third pregnant trimester. A pregnant woman just presents to the clinic or the bathroom or we just woke up in the night, saw herself in a pool of blood, painless bleeding. In most cases, painless vaginal bleeding. Placenta praevia is the first differential to put into your mind. At times when you have these minors, the patient might not even present with any bleeding. It could just be an accidental finding during routine ultrasound scan. When you scan a woman, you want to look at the baby, you want to look at the placenta, and suddenly you notice that, oh, this woman from the history does not even present with any case of name bleeding. But here's the placenta that is almost encroaching on the entrance of the womb.
So this is a case for why people must go to hospital to register.
Yes, it's the way you see.
Because if I delay more, there's no way the lower more you see, scan.
That is why antenatal care is very vital. Because pregnancy is always being described as an unknown journey. Because you never know the whole package from outside.
Keeps unfolding.
Yes. See, by the time that's why when you look at managing a pregnant woman, the scan at the middle and the late part of the pregnancy is very important because you want to be sure where's the placenta. Despite the fact that the woman did not present with history of bleeding. Because it is not in all placenta praevia, even the major, that the patient will present with bleeding. So, I've never bled, I'm 9 months. What they are discussing is not likely to be important to me. No. You need to do a scan and look at where exactly is the placenta. So, in terms of how the patient presents,
because sorry, I'm not cutting you short because I like to put some of these things our patients say. Some patients are just only concerned about what will be the sex of my baby.
Exactly.
How is my baby okay?
No, exactly.
They don't bother about that placenta because they don't know, and that's one of the reasons for discussing this topic in this program, so that the people get to be aware that apart from asking after the baby or asking after the sex of the baby, you should also be concerned and have knowledge about the location of the placenta. Sorry, you can.
Yes, you see, as an obstetrician, the sex of the baby is never important. In fact, personally, I don't look for it. My patient knows I don't look for sex of the baby. What is important is that, is the baby inside the womb? Is the baby healthy? Is the baby all right? Is the baby growing according to the age of the pregnancy? Then where is the placenta? So, because all these, the answer to all these questions will actually determine the mode of delivery.
And the outcome of the pregnancy.
Yes, and the outcome of the pregnancy. So, the idea of, oh, I don't need to register a pregnancy, I don't born more than 5 times, that's even a risk.
Big risk.
Because the more you have been pregnant in the past, the likelihood of placenta previa. The more you have been pregnant in the past, the likelihood of other complications of pregnancy like preeclampsia and other things. So I get experience for belle. You know, they worry me. No, that's a dangerous decision. A pregnant woman needs to register, and the managing physician needs to critically look at the pregnancy and be sure before you take the woman into the labor ward. Take for instance, let me just bring it in. There was a scenario. A woman was brought in bleeding in pregnancy, did not register anywhere. And try to see, okay, that's why I think as a physician, or as a gynecologist, an obstetrician, when you see a woman bleeding in labor, the number one thing you will never do is to put your hand to want to do a vaginal examination. Because you are not sure where the placenta is.
If the placenta is previa, then
yes, if the placenta, by the time you stick into your hand, you open a tap of blood, before you know it, the patient could pass on the table there. So, you must be sure where the placenta is before you stick out your finger to say, okay, let me examine the woman. Just say a woman just came in and something was coming out. Behold, the placenta was coming out.
The baby was still up there.
Yes, and from the history, she had delivered 5 times in the past without any problem. In fact, she normally delivers at home.
She not believe that she's an expert in
delivery. That she always delivers at home. Anytime labor come, just call her neighbor. When I come and catch the baby, the dead don't they come out. But this one not. Placenta they come out. Neighbor cannot catch it.
So, Dr. Adebayo, apart from painless bleeding, are there other manifestations? You've talked about painless bleeding, yes. You've talked about incidental
ultrasound finding on ultrasound.
Any other presentation?
Yes.
Other way that
you see, if you have a pregnant woman, and instead, normally, in most cases, the baby will come with the head. The head will fix down in the lower part of the womb, and everything will fix down in the lower pelvis. But when you see a pregnant woman in advanced pregnancy, the baby is lying across, or the baby is coming with the leg.
Transverse
number
line.
One thing that, yes, well, breech presentation or transverse line. Number one thing that will cross your mind, is there anything occupying that lower segment that made the head of the baby not to fix into it? So those are the things you see when you see a woman that has a breech or footling breech, and you just walked in, if he has never done a late pregnancy scan, that's the time to quickly do one. Because you have to be sure where the placenta is located. Because once the placenta occupies the lower segment, the head of the baby that is normally fixed as if it was molded for it, will not fix again.
So
because a foreigner has occupied the normal place for the head of the baby. So the baby will just look for anywhere it could lie across, we call it oblique, it could lie totally transverse, and it could be coming with the leg. Because, so those are the things that could make a thought that, oh, could it be a placenta previa? Then, you see, when a woman registers, most of the time, our pregnant women register late. Always take the detailed history from the beginning of the pregnancy. Because most of the time, they will just tell you, oh, when the pregnancy was around 4 months, 5 months, I saw blood for a few days, and it stopped. Because the bleeding of placenta previa, most of the time, we stop on its own. It does not even need paracetamol. Though at times it could be torrential, and the patient could bleed and bleed like that. The next bleeding could be in labor.
And that would be the
Oh, no, that's the final blow. That's the final blow. So, usually, you take a detailed history. Was there any bleeding in this pregnancy? If it's okay, there's no bleeding, fine. Then you need to look critically again. As the pregnancy is advancing, in late pregnancy, you must do a scan to look at where the placenta is. Now, after looking through all that, then the decision now is, okay, now you have placenta previa. What is the way forward? Fine. The way forward could be one out of two. It could be that the woman can still be allowed to have a vaginal delivery.
If it's minor?
Yes, if it is minor. But notwithstanding, there are still some minor that bleed like major.
So you have
so
to.
it's under the yes. That's
So it's
right.
like
If a
that
woman
placenta
has
where-
placenta previa and is bleeding, usually you admit the woman until she delivers. Because if she opens up mid in the night at home, before she gets to the facility,
problem.
she might bleed to death. Because placenta previa is the commonest cause of bleeding in labor or before delivery. Yes,
That's
what we call the
antepartum
antepartum
hemorrhage,
hemorrhage is the major cause of it. Now, then, if it is major, of course you need to counsel the woman. No woman will say will not be the mother of a child.
Of course.
You need to counsel, madam, this placenta is already blocking the way your baby will pass through. This baby cannot pass through here. Let us cut through and do operation to bring out your baby. Of course, when you operate them, the operation does not prevent them from bleeding. But there are ways you handle it on the table when you, after removing the placenta, you make sure you underrun the placenta bed to prevent bleeding on the table. Because who's ever had bleeding before delivery, might have bleeding after delivery. That's why we said antepartum hemorrhage will always give birth to postpartum hemorrhage. So the management now depends on where the placenta is exactly. If it is a minor and you could supervise very well, you could allow vaginal delivery. If it is major, the patient go for cesarean section.
What if it's a minor? And because I still know that some had some degree of minor, maybe not really minor close to major,
Yes,
and the woman starts bleeding.
That's why if you have a placenta previa, the late pregnancy scan or pre-delivery scan should have a critical look at what is the location, what is the distance between the edge of the placenta and the entrance of the womb. In fact, in developed countries, because of the facility, they understand everything. Some will go as far as doing what we call magnesium resonance imaging.
Am I right?
Yes, to really locate where exactly the placenta is compared to where the entrance of the baby and where the womb will stretch to as at the time the womb is opening into full dilatation.
So that they will be able to ascertain whether
so that they won't go halfway in delivery and now run into excessive bleeding and start doing emergency cesarean section.
So what we're saying now is that if you have a minor and the bleeding is
if you have a minor and it is far, when you look at it, it's far that as at the time this woman is fully dilated, you could still manage the woman, the baby to come out. Definitely you could allow vaginal delivery. Placenta previa does not mean that all placenta previa go for cesarean section. No,
but what the scenario I'm painting is this: the scan and everything has told you is minor.
It's minor.
And
that does not rule out that you allow the woman to just go and deliver anyhow. It must be supervised, and even when it is minor, and the scan has told you that no, it's still a little bit far away from the entrance, you still need to have a double setting. While she's in labor, get your theater ready. So that at any time you know that you can swing.
So once there's any torrential bleeding, you know that you can.
Yes. So you must always have blood ready when you have placenta previa in labor. You must always have blood. Either you use it or not, you must have it ready.
So means placenta previa must be managed in a center where
there's facility for immediate cesarean section.
And also there must be blood available.
There must be blood available. And it's not the kind of person that will be in labor and you not put a line on the patient. The patient must be on line as if the emergency is at hand now.
Okay, Dr. Adebayo, we are still discussing placenta previa on Earth Crisis in this program taking place on MITV. We'll take a break for the voice pop. When we come back, we'll look at the complications. Stay tuned.
No, I have not seen, but I've heard, but I've not really seen anyone. So I'm not a medical doctor, so I've not experienced that yet.
I've heard. That's what I've seen. My sister had such medical challenges and all that. She was pregnant and she went for a scan and they said, there was this placenta was having issues with her. So I don't have the details anyhow, but I know there were issues that had to do with placenta.
I've heard of it, but I've not seen. I don't know anybody in particular that have it, but I've heard of it. Yeah, because I'm a mom.
I've not seen a woman that is pregnant and have placenta issue. I've not. Because they attach the woman and the baby together in the womb.
Welcome back. You are still tuned in to Health Crisis program on MITV. We are discussing placenta praevia. We've looked at the causes, we've looked at the definition, we've looked at the management, and looked at what should be done when a woman has placenta praevia. With me in the studio discussing this in the past couple of minutes has been Dr. S.K. Adebayo, a consultant obstetrician and gynecologist. Dr. Adebayo, right, you've talked so much about placenta praevia, and I'm sure our viewers have learned quite a lot about placenta praevia, which, even though it's not a very common thing that people talk about, but they do occur, and that's the essence of this program, for people to learn and know about things that are not so common, but that can happen and can be fatal. Now, we want to look at the complications of placenta praevia. What are the complications? What are the likely complications of placenta praevia?
Yes. Placenta praevia is an obstetric condition. So in obstetric condition, we talk about complications in two ways. The complication to the baby and the complication to the mother. Now, the fetal complications, that is the complication to the baby. You know, I said the feeding and the nourishment of the baby comes through the placenta. So if there is any problem with the placenta, that means there will be problem with the baby. So most of the time, it could lead to early pregnancy loss.
Does the
Woman
mama
have placenta praevia at the second stage, second trimester, and she keeps bleeding and bleeding and bleeding until there was no supply to the baby and the baby died inside.
So one will be a miscarriage, using
Yes.
as the layman's language.
Yes. And maybe the bleeding was just not so much. Once in a while it comes and all that, and there is poor supply to the baby. The baby could have intrauterine growth restriction, baby not growing to the age of the, or the expected age of the baby. Then it could also, as part of the complications of the baby, like I said, even during delivery, because you're already coming through the placenta before the baby. During delivery, there could be death right on the table, on the table there.
Because like the last scenario that you painted,
yes,
when placenta was
already coming,
and once placenta comes out,
of course, by then the baby was
no more oxygen to
yes.
the baby, so there's bound to be fetal death at that point.
Now, to the mother, basically the mother is bleeding. The woman can have anemia, shortage of blood. I remember I had a patient with placenta praevia. She had about 2 or 3 transfusions during pregnancy, and during delivery to during surgery too, she had about 6 pints of blood and all that. So the bleeding is a major factor to the woman. It also increased the rate of cesarean section to the woman. Most of the time, when you have major cesarean section,
there's nothing anybody can do about it.
There's nothing anybody can do about it.
And if the
now, when you now look at cesarean section and all the complications that's attached to cesarean section, those are the complications that could occur with placenta praevia, both in the mother and in the baby.
As you are saying this now, something just occurred to me that we hear from our patients. You have a reason for telling the patient you need a cesarean section, and say, you never happened for our family before.
I reject it.
I reject it in Jesus' name. Not our family. And if that patient has placenta praevia, I'm sure some of them are listening. They will not know that there's no other option. Yeah. Because the doctor will always say there's need for surgery when it is necessary to save that life. You say, nobody has done it in my family before, you know?
Yes, that's where the orientation of our people comes in. Such thing you don't find in developed country because they are more civilized. Then when you look at it too, even here we have mixed crowd now in here. We have people that are well educated. They've even read about all these things. They are the one that will say, doctor, if you know, even though you are telling me it's minor, if you know that I'll be bleeding during the so-called minor, just take me to the theater and do the surgery. You see, the issue of placenta previa is, once it is there, yes, fine, it's not that common. But then, it's been shown that in most cases, we have one case of placenta previa in about 250 pregnancies. So it's still nothing that is so uncommon, you know. Then, in some situations,
and from many years now.
Fumi calling from, okay. Hello, Fumi.
Hello? Hello?
Can you take your question again, Fumi? Oh, we lost that caller.
Hello?
Fumi.
Sir?
Yeah, what's your question?
My question is that I'm doing period, but anytime I'm doing my period, I always have a pain. And for me to have, for me to pregnant is no, I cannot pregnant because I don't know what is going on with me. Even now, I'm having the pain when I'm doing the period. That's all I call. I saw the number and I said I should call.
You understand what she's saying? That she sees blood. She's not pregnant and she missed her period and she sees blood. And like she don't test and says she's not pregnant. So
there are two things. I think we should correct this erroneous belief of our people. Some will tell you that when I'm pregnant, I still see my menses. A pregnant woman never menstruates. And a menstruating woman is never pregnant as at that time. So if you missed your period, there could be other reasons why you did not see your period apart from pregnancy. If pregnancy test has proven to be negative, if you do a genuine pregnancy test,
that's able to.
Oh yes, if you do a genuine pregnancy, you are seeing blood, you are not menstruating, and you are not pregnant. You need to see a gynecologist to have a proper look at it, because now I don't know your age. Yes, a woman came to me sometimes ago, 43-year-old, and said, "Oh, thank God our menses are ceased." She now yes, and lo and behold, by the time we put a speculum and check, she has a cancer of the cervix. So you see, if you are bleeding, you are not menstruating, then you need to see a doctor to find out what is actually wrong. You need to know where the blood is coming from.
So you can be part of this program by calling us on 090-9930-9928 and as on the screen. Yes, we know we were talking about complications before that call came in. So we also take calls as they come in. You were looking at the complications. You talked about bleeding being the major complication.
Yes, bleeding is a major complication.
I want to ask a question.
Yes, carry on. Go ahead.
As in, I'm like 6 months pregnant now, and my test is like my pregnancy is my baby is lying down on my pregnancy, so there's no space or something like that. I'm having small abdominal stuff.
Okay.
You heard what she said?
That she's 6 weeks pregnant.
6 months.
6 months pregnant.
She's having some pains.
She's having some pain.
Before you answer the question, it reminds me of what some people say. You know, that they are pregnant and maybe the baby put the leg somewhere or put the head somewhere. You know, I just remember that what people say. But maybe just take that question.
Yes. She said she's 6 months pregnant.
And she's feeling some
pain. She's feeling some pain. Well, the pain you are feeling, you see, that's why we don't just look at that as an information. We want to know, is this pain comes once in a while? Or is it the pain you feel when you stress yourself and by the time you rest or sleep, you wake up in the morning, you got over it? Or is it the pain that comes and goes like contraction? When you are seeing this pain, is this pain disturbing from doing your normal activities? Is it associated with bleeding from your vagina? Or are you seeing water from your vagina? So, after telling us that you see pain, you have not given us all the information. We need to have all other information so that we know exactly what could have been the cause of your pain associated with this pregnancy. You could even have pain and body pain and fever, which could be malaria and pregnancy.
Maybe pain from
exactly. So when next you get to the clinic, please explain to your doctor. Your doctor will take a detailed history of likely cause of the pain and you'll be treated accordingly.
Right. So she should visit
Let her visit her doctor so that they'll be able to look at it. Because a pregnant woman, don't keep complaining to yourself. You must take your complaint to your doctor. Even if you not get that, doctor say, don't worry, it's a minor thing, then you'll be happy that at least you have cross-checked it and you're in a safe line.
So we're talking about complications.
Yeah. Like I said, complication of placenta previa could start from bleeding during that pregnancy. It could also lead to abnormal lie of the baby. Okay. Now as the pregnancy advances, the bleeding could come back again. Okay. You might get over that bleeding. The patient could be pale. Some placenta previa could bleed to the extent that they might need to be transfused during that pregnancy. Okay, the pregnancy is going on.
Well, I think we have a caller. Okay. Bola also. Hello. Okay, maybe we lost the caller. I think we lost the caller. So,
okay, now like I said, as we are coming along with the pregnancy, we are looking at the complication. The bleeding, the abnormal lie of the baby. Along the line, the bleeding becomes more, the woman is pale, the woman now needs some blood transfusion. Perhaps along the line, because of the level of the bleeding, the pregnancy is lost, or baby died inside around that time, or maybe, okay, we move towards again, as delivery advances, the bleeding could reoccur again. Then in labor, assuming somebody who's never registered anywhere, who has never done any scan, just came in bleeding and all that, the doctor must be watched before you put your finger there. You have to be sure, where is the placenta? Do you have a scan done? Okay, as the pregnancy, as you go on, whichever way you go, you deliver vaginally, watch out for bleeding. You have cesarean section, watch out for bleeding. Even after you have finished the delivery, you still need to monitor after that for bleeding. Then before you discharge the patient home, you check the blood level, because all along she might be coping with the bleeding. By the time she delivers and everything is okay, you now check the blood. You now discover that maybe she still need transfusion before you discharge home.
Because she lost more blood.
Yes. Or she'll be losing blood. She'll be losing blood gradually along the line.
And you added to the one of delivery.
Exactly.
So we're looking at the complications. But let's quickly just we know we've said it as we were discussing the diagnosis.
Yeah. So, you see, in diagnosing in medicine, we start from the history of the patient. It's maybe when you are looking at, when you are talking to the woman, he has some issue.
I want to ask a question.
Hello.
Hello.
Yeah, what's your question?
Okay, my question is that I'm 2 weeks pregnant.
Okay.
Hello.
I can hear you.
Okay. Hello, good evening.
Talk on.
Okay, my question is I'm 13 weeks pregnant.
13 weeks.
13 weeks.
And I've gone for a scan and they said the baby is okay. But today, I was having cramps throughout today.
Okay.
Okay, so 13 weeks pregnant.
You're 13 weeks pregnant
and having cramps.
You're having some cramps. You are not bleeding.
Okay, maybe she's
okay, let's assume if you are bleeding, definitely you will have mentioned it. You have some low abdominal cramp. Basically, at that level, one of the common causes of cramps and low abdominal pain, and that's it, might just be urinary tract infection. So, what I would advise is that you need to visit your doctor, because if you leave a urinary tract infection untreated, it could lead to miscarriage. So, the best thing is to see your doctor. Taking pain reliever to just subside is not enough. You need to see your doctor and find out the underlying cause of it. If coincidentally, some might have cramp like that, and all you find by the time you scan the woman, all you see just a fibroid that is giving the cramp. Or when you do a urine culture, it's all urinary infection that is causing the cramp. Urinary tract infection. So the underlying cause, you need to see your doctor.
So let's quickly look at this diagnosis.
Okay, the diagnosis of placenta previa. Basically, from the history, you have that, and the patient is talking about bleeding. Present with painless bleeding. That's not enough. Then you need to do an ultrasound scan. In ultrasound scan, you'll be able to locate the placenta and know where exactly the placenta is. That gives us a definitive diagnosis of placenta previa.
Okay. All right, Dr. S.K. Adebayo, it's been a pleasure having you on the program discussing with you.
Thank you.
Viewers, I know that you have learned so much about placenta previa. Some of you have become masters of placenta previa. You have learned that any painless bleeding for a pregnant woman, you have to see your doctor. It is important that you register for antenatal in a hospital when you are pregnant, not just assume that you know it all, and it's good to register early. And for those who are diagnosed as having placenta previa, you must make sure that you are managed in a facility where cesarean section can be done. Because you may say you have a minor PP, placenta praevia, and it becomes a
minor could bleed.
So we advise that you do all this. The program is Health Crisis, and where we look at common medical conditions. Today, we've examined placenta praevia. Next week, we will take on another very interesting topic. We hope that you'll be with us again. Have a wonderful evening.